Good day, everyone, and thank you, Anne. I'm honored to be part of this premier global healthcare conference, the Path Forward 2020. That pandemic has created an urgent demand for action leading to sustainable change. Throughout the pandemic, there has been incredible attention and awareness about the role supply chain visibility, traceability capabilities play in delivering safe and sufficient healthcare while protecting all patients. Never has a global, secure, efficient supply chain been more important. GS1 stands for Global Standards 1. As a non-for-profit, we have significant recognition for the global standards development and implementation of what you would know as the barcode. Through 115 GS1 member organizations around the globe, GS1 establishes and maintains global standards for supply chain to enable the world to digitally speak using one global language. The integration of GS1 global standards in healthcare is the key foundational step to building a robust, digital, and clinically integrated supply chain, as recognized in the HIMSS seesaw model. However, unless we have the commitment in the community to adopt these standards within clinical and non-clinical workflows, we will not truly achieve the vision of patient safety and realize significant efficiencies in the healthcare system. This morning, I have the pleasure of welcoming Mr. David Berridge, Deputy Chief Medical Officer of the Leeds Teaching Hospital NHS Trust, who will deliver the opening keynote. David will share his digital transformation experiences. His commitment to sharing the journey allows us to learn not only about the experiences, but we can grasp the value and outcomes of a clinically integrated supply chain. David and the NHS team have truly put global supply chain standards into motion. GS1 UK worked closely with David when the Leeds Teaching Hospital NHS Trust was selected as one of the 6 demonstrative sites that participated in the Scan for Safety initiative. This pioneering initiative, led by the NHS Department of Health and Social Care, investigated how consistent use of point-of-care scanning of barcodes produced by the GS1 global standards can improve the efficiency and safety within the NHS. David is also an integral member of the GS1 UK Healthcare Advisory Board, GS1 Global Healthcare Clinical Advisory Committee, and shares his experiences and inspires healthcare providers and governments around the globe. Please join me in welcoming David as he delivers his keynote, Driving Global Standards to Improve Patient Safety and Positive Care Outcomes. Welcome, David.
Thank you. It's a pleasure to join you today. My name is David Berridge. I'm the Deputy Chief Medical Officer at the Leeds Teaching Hospitals in the United Kingdom. What I'd like to talk about today is how we've used global standards and in particular the Scan for Safety programme in trying to further healthcare and the quality of that healthcare. So our trust comprises 7 hospitals, and you can see on the map it's a disparate group of hospitals from the very large to the small bespoke community hospital. We cover the whole range of facilities, both for adults and children, and in fact we're the largest single provider of specialised services in the United Kingdom. So what do? We see over 1 million patients in outpatients per year, nearly 250,000 people in our A&E departments, and nearly 9,000 babies born every year. Our budget is 1.4 billion with 18,000 staff, and we cover over 100 different specialties. We've also been fortunate in attracting further funding in excess of 600 million to allow us to build a new children's wing, new children's hospital, I should say, and a new ambulatory care centre on our Leeds General Infirmary site. And that is very exciting news for our staff and indeed for our patients in the forthcoming years. In addition, we are part of the West Yorkshire Association of Acute Trusts. There are 5 other trusts in this organisation spread throughout West Yorkshire. This amounts to over 5,000 beds, in excess of 40,000 personnel, and a combined budget of 3.35 billion, supplying healthcare to some 2.6 million within that catchment area. And in addition to that, are the tertiary and quaternary services that I alluded to earlier. So where does Scan for Safety come in this? Well, it was initially started as a procurement programme, but very quickly people realized that this had significant clinical benefits, and hence the term scan for safety. And it has four main elements: the patient, the product, the place, and the process. And you can see on the slide that these are absolutely imperative to good quality care and to improve in efficiency throughout our healthcare in all the various different areas that it is provided. So what benefits were realized? We'll come to some of those in detail, but in the preliminary stages, there are a number of soft benefits and indeed a number of indirect benefits. But these all center about improving efficiency for our patients, directing resources where they are really needed, and to make the maximum use of the resources you already have. This was a 2-year program, and from startup to finish of the 2 years, including learning curve, including startup, we were able to return 2.3 million from our 2 million initial startup costs. This is the early days. Most of this time was development. Most of this time was getting the basics in the system. And a lot of these costs were recurrent savings, not just one-off savings. So let's look at this in some more detail. We look at the patient label first, the GSRM. Every single patient coming into any one of our hospitals for inpatient or day case treatment, whether they are an adult, a child, or a neonate, and indeed all patients coming into our 2 major A&E departments who require investigation, all have a GS1 compatible wristband. Every single place that that patient could ever be treated or managed throughout the organization now has a GLN. And those GLNs, in addition to having a GS1 compatible barcode and or 2D matrix, they also have passive RFID. So if we ever need to change the functionality of that particular clinical area in the future, it's a relatively straightforward process. And increasingly, our electronic catalog allows us to scan products from start to finish in the procurement and supply business of our healthcare. Let's look at this in more detail again. The patient location. What you're seeing on the slide now is actually real and enacted in our hospital today. We're using iPads which can scan the matrix on the patient's wristband, and you'll see on the left of the screen a number of icons. These icons are touch facilities to access the electronic patient record, the electronic observations, the eMeds facility, and indeed tracking that patient not only down to individual bed space, but with those GLN extensions allowing that bed space to be labeled, occupied, ready, or waiting to be cleaned, which is very important for the whiteboards, which you can see on the right of the screen, not just for that individual ward, but indeed for the 114 wards across our organization, so that our staff can make best use of resources and they know where those beds are available. If we look at this, we've developed a mobile app, and this was launched back in November 2017, and this shows you the tracking of that patient through different areas on their journey in the hospital. So we don't have any longer in our breast digital ward, where is that patient? Is she having a needle biopsy? Is she having a wire insertion? Is she on her way to theatre? Is she in recovery? So that whether it's our medical staff or nursing staff, or indeed if it's that lady's relatives, we know precisely where she is in the journey, allowing more efficient time and more efficient use of those theatre schedules. If we move to the live bed state, we can now see across our organisation a near live bed state. We're using our GLNs and our GLN extensions, which label each bed space we have available throughout the trust, combined with our PAS data at the present time. So this is near live. At the same time, we have 6 wards which are using digital scanning, using the GS1 barcodes to effect a true 24/7, 365-day a year live bed state. The reason we're doing that is we, at the moment, have quite an old PAS system, which is being replaced next year, but at the moment, we have to do that trial to make sure there's no nuances which will cause inaccurate data. But we're hoping to change to a fully live system within the next year. Let's now turn our attention to infection prevention and control, and clearly that is very timely as we're all within the middle of the COVID pandemic, and indeed in Leeds here we're now seeing the first stages of that second surge. Going forward, we need to know precisely which patients have been in which beds, who have been associated in the surrounding beds over a significant time period. Using this data, we will be able to track those patients. We will be able to test and trace for whatever conditions, not just COVID, but whatever other infections come our way in the future. There's some really important, exciting development in medicines, and this particular slide refers to CAR-T tracking. Many of you may well know what this is. For those who don't, it's an important new development in the treatment of acute lymphoblastic leukemia and also some of the large B-cell lymphomas. This allows the patient's blood to be removed, to be sent to a specific off-site facility where that patient's T cells are then modified with virus to allow them to be re-injected into that specific patient to fight the tumor. This is really exciting front-edge stuff, which will allow those patients to have much better outcomes and a more effective and long-lasting treatment. This is a really exciting development for Leeds, and we're looking at that tracking of those specimens, not just for Leeds, but on the national arena as well. We now look at equipment tracking. Some of this will be with using the barcode technology, but equally some of this will be using RFID. And in this particular example, we can see a vasotherm device which is used throughout our neonatal critical care areas so that we can make best use of this expensive equipment. We don't have to buy multiple versions and multiple copies of these types of kit just because we don't know precisely where they are and how readily accessible that they can be. And we've used these for bladder scanners, we've used these for cardiac ultrasound machines, and indeed we've got them on our electronic infusion pumps throughout the trust. Let's turn to inventory management now. This used to be quite a labor-intensive, paper-driven exercise. And you can see from this slide some of the very new cabinets in the top left. They may not look terribly exciting with plastic fronts on, but these are the WaveMark RFID cabinets for expensive individual items such as pain stimulators and indeed cardiac defibrillators. Very expensive stock. We need to make sure that it's all in date. We need to make sure that those stock levels are instantly replaced. So the whole procurement access is performed by RFID. As soon as you move one of those devices, it is instantly reordered to maintain the stock in those cabinets. Paper-free inventory. Again, we now have a situation for our stocks on all of our wards that from beginning to the end of the process, the stock is scanned when it arrives into the trust. It is then scanned in individual stock holding areas. And again, those stock levels are monitored and reordering is using GS1 barcode technology and scanning. I want now to turn to the question of product recall. Product recall happens many, many times per year. In an organization our size, we may have as many as 500 product recalls in a year. They won't all be major product recalls, and they won't all be headliners, such as the breast prosthesis or the metal-on-metal hip prosthesis. But I've just given you one example in this slide to show how it used to happen, but equally how it happens now. So in the middle of the slide, you see a photo of theatre book covered in small little sticky labels which represent the prosthesis and all the Teflon pledgets and all the pins that have been left inside that patient. And to track such a product recall would take an army of people over a considerable length of time, and I certainly wouldn't be reassured as close to 100% as possible, even after a considerable amount of time, that they had necessarily captured every single patient, every single product. And if you look at the bottom of the slide, how different that can be. And this was just one example recently. We had an alert at 10:15 a.m. in the morning of this particular device. And you can see in that alert, there were in excess of 800 product lines. Within 1.5 hours, not only had we identified every single product on the shelves, we could also identify every single product that had been used down to patient level. And I was able to receive a confirmatory message 1.5 hours after that message came into the trust that the entire process had been completed and we were safe and we knew what to do with all affected patients. We turn to never events. Now, never events is a system that was introduced in the UK a few years ago, and the clue is in the title. These are events that really shouldn't have happened, and it is believed that there is sufficient mitigation to have prevented them. So they are now flagged up as a serious incident and investigated accordingly. So the data I'm showing you is national data. This is from a 5-month period earlier this year. And you can see that 115 incidents were recorded as never events. If we turn to the next slide, when you analyze these 115 events, if we had a system where you can scan a patient, we do. They can scan a place where that patient's being treated, we do. They can scan a theatre list down to individual OPCS code, that is possible, currently not functional, and all you then have to add to it is side, i.e. right or left, which is perfectly possible. You can see that the vast majority of these never events could have had a further electronic mitigation to try and prevent. And certainly we and others are looking at trying to develop that as soon as we can, because we believe that would be a further step to enhancing patient safety. I now turn to catalogue management, and this slide shows you 3 very different devices. One is a heart valve, one is a syringe, and one is a catheter system. And you can see within the red circle, they have identical catalogue numbers. Now that shouldn't be allowed. That we need to insist on all our suppliers that they do have individual GTINs so that we know precisely what they are and we can rely from institution to institution that we're getting exactly the same product in the same format every time. I'm going to move quickly on to blood tracking now. This is a significant investment that we've performed over the last year, and we're now able to put in a Haemonetics TX system combined with intelligent blood fridges, and this will allow digital scanning from the moment the blood is taken from the patient on our wards with a bedside produced GS1 labeled barcode, which goes straight onto the blood sample bottle itself. It only needs one person to take that sample, and that will then still satisfy the, in quotes, 2-sample MHRA requirements for blood products. It is then digitally tracked throughout the patient's, throughout the process of that sample into our blood bank, production of blood or blood products, back into the intelligent blood fridges, and again back to the patient, whether he or she is in theatre, on the ward, or in any of the interventional suites. All digitally managed and monitored throughout. It doesn't replace the human checking of identity at the end, but it does supply an electronic solution of checking you have the right patient with the right blood sample in the most cost-efficient way. Our return of investment on a 1.2 million programme is less than 2 years. Our waste reduction in terms of qualified nursing staff across our organisation is 13.5 whole-time equivalents per year. And in this day and age where registered nurses are a very precious commodity, 13.5 reduction over a year is a very significant advantage, never mind the financial savings that we've also demonstrated. Let's turn to EOBS now. Throughout our 114 wards, all patients now have access to electronic patient records, electronic observation recording. And we've developed this further. There was an incident a couple of years back where a patient had a recording of 37.5 centigrade. This patient was waiting for a liver transplant later that day. The protocols insisted that that transplant could not go ahead, because of the risk of peritoneal sepsis. The operation was deferred. It was subsequently discovered that that was an erroneous reading. Again, should never happen. We've now developed the software that you have to rescan the patient's GS1 band prior to being able to admit any EOBs into that particular patient's record. So even if you've moved to another patient, if you've not closed down that patient's record, it will not accept EOBs from another patient. Finally, can I turn to the COVID-19 response? And this has required a number of changes, but it's also flagged up a number of limitations, which hopefully in the future we can reduce or even eliminate further to further the case of global standards and to further the case of improved healthcare and quality of healthcare. Our starting position, as depicted in this slide, shows where we were at the starting of this epidemic. We, like many other institutions, had spent many years trying to be lean, trying to reduce the stock on our shelves down to a minimum compared to the lead time for that product. COVID occurred, and then suddenly we needed vast quantities of PPE. Our storerooms couldn't cope, so we took over a number of seminar rooms. Cramped, but necessarily they did the job at the time. But it's clearly hard to track, and it's clearly hard to monitor, especially when a good deal of this stock comes from different countries around the world. And quite often, even if they had a barcode on the outside of that package, it wouldn't be GS1 compatible, and equally, it wouldn't necessarily refer to what was actually in the box. So how have we gone around that? Well, we've moved from that position to acquiring a warehouse, which is literally just out of the rear entrance of our major site at St. James's. This now holds currently in excess of 7 million items of PPE, and we've combined this with electronic measures, and I can just show you on this next slide, the PPE analyzer tool. I now have live access throughout the trust to the stock which is held on all different PPE items, all different FFP3 masks, and we use this to determine what our holding is and how many days we could manage without further supply. In association with this is a further tool on the next slide, the PPE forecaster tool, and we've actually been using this very morning. We currently now have 170 patients with COVID in our hospitals, and this tool can predict how much extra PPE we would require should we have any number of extra COVIDs. And we've modeled this morning from anything from 200 to 300 to 400 patients. And I know that we have sufficient PPE stock, even if we have a further 200 COVID patients to last a minimum of 14 days. That is a very comfortable position that we managed to get ourselves into. So what I'd like to do finally is thank you for your attention. I hope I've demonstrated a number of things that we've been able to do here in Leeds, emanating from the Scan for Safety program. There's much more work to do, and COVID, I think, has actually demonstrated if we had universal coding throughout the world, we would know for sure what we were getting. We would be able to monitor and track that stock so much more easily. And when this pandemic is over, I do hope we remember many of the lessons we've learned during it and during our time with scanning. Thank you very much for your attention.
There we go. I'm unmuted. Thank you, David. It's, you know, taking vision and implementing vision is very, very different. And you've proven results. So it's absolutely unbelievable just to sit here and listen, because as we talk about the barcode, that's just one of our keys, and you've used all the GS1 keys predominantly within your deployment. So we thank you for that. And it's incredibly inspiring. I'd like to move, if you're comfortable, into the question time frame.
That's fine.
Okay, I have a question that's already put forward. And this question is, so over the years, the role of healthcare supply has transitioned from getting product from the basement to now being recognized as one of the key strategic areas to drive patient safety, efficiency, and critical analytics. As a clinical leader, how do you now view and depend on supply chain, including the use of the standards such as the barcoding? This one, I don't have a name for this one, but there you go. That's the question.
So Eileen, the sound just changed a little bit in the last aspect of your question. Could you just repeat the last aspect of your question?
Yes, as a clinical leader, how do you now view and depend on supply chain, including the use of the standards such as barcoding?
Thank you, Eileen. Well, I hope I've demonstrated in the lecture that we rely implicitly on it. And whilst this has always been a fundamental requirement for an efficient health service, and we all live within a constrained financial envelope. So to buy in the engagement of our clinicians and our managers and indeed our executive team, what we did right at the beginning was show them what could be done. So we brought in all the different manufacturers, we brought in all the different facilities, and we showed them, if you like, a live simulation end to end through the wards, through the theatres, through the patient experience of what this could demonstrate. And that's how we achieved really great clinical engagement. In terms of that supply and procurement angle, to try and affect better healthcare and improved healthcare and to allow innovation and investment, it has allowed our clinical teams to show how you can achieve waste reduction by close information showing you where the waste happens, either with stock going out of date or with excess stock on the shelves, or indeed looking at alternatives where their colleagues or their peers might be using a cheaper alternative which has just the same quality or better, has allowed that engagement to allow us to reinvest that money where it's most needed. So there's a much greater visibility now of all of our clinical staff and indeed our managerial staff within the trust of what Scan for Safety, what bar scanning can really bring in terms of efficiencies, in terms of allowing that re-innovation. I've mentioned just two of the invest to save projects, the Hemonetics blood bank system. We didn't have a spare 1.2 million to invest this year, but that business case was irrefutable. We knew we'd get that investment back within 2 years. We knew we'd free up 13.5 whole-time equivalent qualified staff. And we've done similar things in pathology with auto-slave devices. So it's a way of convincing your director of finance to allow that investment to happen, knowing that return will come in and will come in quickly. And it allows your clinicians the freedom to innovate, to progress and improve the quality and safety for our patients.
Great. Thank you, David. I have another question for you. So this one is really important in Canada. So the executive and government leadership is critical to any system-wide deployment around the globe. We've really been watching what you've been able to achieve. So here's the question. How important has government and executive leadership been to your success as a clinician and to your hospital?
So first of all, from a government perspective, clearly the Scan for Safety initiative was a fantastic starting point. As I mentioned, when we were first interviewed for that role, it was very much a procurement exercise, but rapidly transformed into a clinically driven project, if you like, in association with finance and procurement, because the possibilities were endless. When we did those demonstrations, not just for our own trust, but for other trusts, when the clinicians come through, when the execs come through, it's more a case of, why can't we do X? And the answer is, well, we can. It's just to develop it and to roll it out. And so in terms of trying to encourage that engagement, that wasn't the problem. It was more managing the expectation and managing what we can do as quickly as we possibly can. And as I said, right at the beginning, it's very important to get your execs involved and to show them what this system can do. And then the doors do start opening for you.
Great, thank you. I have a third question. So during your presentation, you told us how all patients visiting your facility are fitted with a GS1 compatible wristband to enable tracing of their journey throughout your facilities. Once this new operating measure was implemented, how did the public, your patients, react to this new measure?
So we did patient surveys because there was some feeling that would the patients feel that this was Big Brother or something similar, we had absolutely universal acceptance. And to some extent, the comments were surprised that we haven't had this already. They see it in their everyday lives when they go shopping, when they go on travel, when they hire a car. They're all scanned in, their details are scanned in. So why shouldn't you have that same level of security and reassurance within the healthcare environment? So we've had universal acceptance.
Wonderful. And so then how important has the patient tracking been during COVID?
So in terms of tracking patients across the trust, as I said, we've got the patient address on labels on their wrists. We've got the room notification barcodes and RFIDs. We haven't got tracking fully around our trust yet because we've got 114 wards, but we do have that near live bed tracking information. So that has been incredibly useful because it isn't just about the patients who are known to be positive. You've got that whole triaging system of unknown, unclassified patients until they've got their swab result through. You have to have all these multiple different streams. So managing all that myriad of different pathways within your hospitals has certainly been made easier with the help of barcode technology.
Wonderful. Okay, I have another question for you. The question is, do you synchronize your product information with manufacturer data in an automated fashion? And if you do, what registry are you syncing to? And this question came from David Lucas from British Columbia.
So we do use an electronic registry, and that catalog is building literally day by day. I did mention in the presentation that we are expanding this work across the wide group of hospitals. So we now share the same electronic catalog. We have recently invested in the same procurement system. So ultimately, it will allow control not just of our stock, but certainly of high cost items across that much wider footprint throughout West Yorkshire, so that we have a situation whereby nobody needs to run out of stock, nobody needs to have a shelf worth of expensive supplies going out of date, and that we can actually achieve the best contract price across that much wider healthcare footprint. So it's absolutely essential that we have common standards. Wherever possible within healthcare systems, you have exactly the same procurement system. And the electronic catalogue allows more and more procurement to happen through PEPAL rather than any form of paperwork, either in invoicing or indeed in payment of those invoices.
Okay, well, I really want to thank you, David, for it's been inspiring. I can't believe what you've been able to achieve. It's the art of the possible. So you're proven, and so we appreciate your time, your investment, and again, thank you.
It's a pleasure. Thank you very much, Eileen.
Okay, so now what we're going to do is we're going to take a 15-minute break. So please rejoin at 10:30 Eastern Time for the global panel on evidence-based impact and outcomes of supply chain transformation to health systems. Exciting. Thank you.